Dear colleagues, I would like to thank Professor Wu Lezheng and Professor Lin Haotian for inviting me to give the presentation. Today, I would like to talk about allergic conjunctivitis, a very common eye disease. I will talk about the clinical features, classifications, treatments, and some new perspectives, some new findings about allergic conjunctivitis. Allergy is a global challenge. It is estimated that about one-third population worldwide was affected by allergy. Among them, about 40% to 80% have ocular involvement. Common allergic diseases include allergic rhinitis, asthma, allergic dermatitis, and allergic conjunctivitis. Common allergens include dust, pollen, mites, as well as some medications, including some eye drops or ointments. Allergic conjunctivitis is very common, especially in children. They have eye itching, redness, and even vision impairment in severe cases. Typical signs include hyperemia, papillary, and follicle formation. AC is classified into 4 types according to different mechanisms and clinical features. Perennial and seasonal AC are caused by type 1 immune reaction. Vernal keratoconjunctivitis and atopic keratoconjunctivitis are caused by type 4 immune reaction. VKC and AKC are considered more severe than PAC and SAC because they have more severe and refractory symptoms and more likely to involve the cornea and even the whole ocular surface. Specifically, perennial allergic conjunctivitis was caused by type 1 hypersensitivity. Patients tend to have perennial symptoms that have no significant difference among different seasons. The common allergens was dust mites and hair. Patients usually present conjunctival hyperemia, follicles, papillaries, but they usually don't have corneal changes. Seasonal allergic conjunctivitis is also caused by type 1 hypersensitivity. Patients usually present seasonal symptoms. Common allergens was pollens, and the patients also usually present with conjunctival injection, follicles, papillaries, but most of them won't have corneal involvement. Vernal keratoconjunctivitis is also known as spring catarrh. It is an uncommon bilateral allergic disease that usually begins in the prepubertal years and lasts for 5 to 10 years. It occurs much often in boys than in girls. The specific allergen or allergens are difficult to identify. It is almost always more severe during the spring and summer. The patient usually complains of extreme itching and a loppy discharge. The conjunctiva usually has a milky appearance, and there are many fine papillae in the lower tarsal conjunctiva. The upper palpebral conjunctiva often has giant papillae that give a cobblestone appearance. Trantas dots are the whitish dots seen at the limbus. In some patients with vernal keratoconjunctivitis during the active phase of the disease. In severe cases, superficial corneal plaque or the shield ulcer may present. Atopic keratoconjunctivitis is also caused by the type 4 and type 1 hypersensitivity. Patients with atopic dermatitis often also have atopic keratoconjunctivitis. The symptoms and signs are a burning sensation, mucoid discharge, eye redness, and photophobia. The whole ocular surface may be involved as chronic ocular inflammation and subconjunctival fibrosis. Accordingly, the treatment of allergic conjunctivitis includes the following parts. Firstly, health education to the patients are essential. They need to try to avoid contaction with the allergens. They need to improve the living environment, especially their personal hygiene. Secondly, topical medications are important to relieve the symptoms. We may use the antihistamine and mast cell stabilizers targeting at the type 1 hypersensitivity. That means perennial allergic conjunctivitis and seasonal allergic conjunctivitis patients. In contrast, vernal keratoconjunctivitis and atopic keratoconjunctivitis are caused by the type 4 and type 1 allergic hypersensitivity. Therefore, topical immunosuppressants such as cyclosporin A or tacrolimus are required to suppress the activated T cells as well as the mast cells. Short-term steroid topically used may relieve the very severe symptoms in those patients with very predominant itching and conjunctival edema. In addition, artificial tears may help to rinse the eyes and therefore also recommended in the treatment in allergic conjunctivitis. Artificial tears can wash out the allergens as well as the inflammatory exudates. If persistent epithelial defect or even corneal shield ulcer is detected, bandage contact lens and a multimembrane transplantation may help. In patients with severe corneal ulcer, keratoplasty may be an option. AC is a disease more than conjunctivitis. Recently, a significant correlation has been found between AC and keratoconus. Patients with chronic allergic conjunctivitis, especially vernal keratoconjunctivitis and atopic keratoconjunctivitis, have a much higher risk of developing keratoconus, and patients with keratoconus have a much higher prevalence of AC past history. The underlying mechanism remains unclear, but it was believed that frequent eye rubbing and chronic mechanical trauma of the corneal epithelium induces keratocyte and fibroblast apoptosis, and therefore give rise to the development of keratoconus. Myopia is also a highly prevalent eye disease. A cohort study was conducted and confirmed that children with allergic conjunctivitis has a higher incidence and subsequent risk of myopia compared to those without allergic conjunctivitis. Lower refractive error and longer axial length of the globe were observed in an allergic conjunctivitis animal model. Myopia progression can be enhanced by TNF-alpha or interleukin-6 administration, two cytokines secreted by the mast cell degranulation during allergic conjunctivitis. These cytokines can cross the cornea and reach the retina and sclera, and finally link to the microinflammation and thinning of the sclera. The experimental findings in mice collaborate the epidemiological data showed that allergic inflammation influences the development and progression of myopia. Recently, we also tried to look at allergic conjunctivitis from different perspectives. We are interested in several questions: whether microbiome of the ocular surface changes during allergic inflammation, how the quality of tear film be impacted by allergic conjunctivitis, and whether life quality been reduced in patients with AC. The microbial communities residing in and on the human body, along with their genomic elements, metabolites, and components, together constitute the human microbiome. The microbiome affects the host's susceptibility to various immune disorders, including allergy. Understanding the role of the ocular surface microbiome in AC may provide a new target for the development of therapeutic interventions. We collected conjunctival impression cytology species from AC patients and healthy control. Metagenomics analysis shows that the AC is associated with dysbiosis of conjunctival microbiome. The alpha diversity showed no significant differences, whereas the inter-individual variation within AC group was slightly lower than healthy groups. The species composition showed a clear delineation between healthy and AC participants. We further disclosed numerous associated species. Interestingly, we found the enrichment of Maracilla and Malassezia and so on in AC. Then we further look into different types of AC. SAC and PAC were pulled together because they share similar pathogenic mechanism, which was different from that of VKC as mentioned before. The two subgroups harbor distinct microbial signatures. Here shows the relative abundance of the species enriched in VKC compared with SAC-PAC, including Streptococcus, Staphylococcus, and so on. It should be noted that the colonization of Streptococcus pneumonia in airway is the risk factor of asthma, and Campylobacter concisius is related to glucocorticoid resistance in patients with asthma. Therefore, these results show that composition of conjunctival microbiome is associated with the different types of AC. This finding represents potential targets for the microbial mechanism underlying AC and other non-infectious ocular surface inflammations. Meibomian gland dysfunction has been considered as a major long-term complication of AC. Therefore, AC has been listed as a risk factor of over-evaporative dry eye induced too. Abnormal blinking is a common complaint of parents who seek eye care for their kids with AC. Meibomian gland function and blinking are important in the formation of lipid layer of the tear film. We wonder how does the lipid layer and blinking change in patients with AC. We have conducted a prospective controlled study by enrolling AC children and age-matched healthy children as control. We focus on pediatric patients because AC is more prevalent in this population. Research showed pediatric patients with AC had significant thinner lipid layer thickness, shorter TBUT, decreased Meibomian secretion and quality, more prominent Meibomian gland loss, and decreased total blinking but increased partial blinking rate. Such changes were more prominent in those with VKC-AKC than SAC-PAC. After treatment, lipid layer thickness and Meibomian quality were improved, and FBUT was prolonged. Besides visual function, the eye also plays a role in one's psychological, emotional, and subconscious status. It has been reported that chronic eye diseases such as dry eye, childhood glaucoma may affect patients' quality of life. Allergic conjunctivitis, tends to have a chronic course with multiple recurrent episodes, and many patients need to seek medical consultations repeatedly, which may further adversely affect their quality of life. Therefore, it may generate worry, anxiety, depression, or other psychological stress for the pediatric patients and their family members. We recently ran a prospective controlled study to investigate whether there is an association of AC with life quality in children and their parents, and our study has recently been accepted by JAMA Ophthalmology. Results show that total pediatric quality of life scores were reduced in patients with AC. The reduction in health-related quality of life was more severe in children with VKC, AKC than those with SAC, PAC. There are 4 major parts included in the questionnaire. Among them, school functioning was the most significantly impaired. Besides that, physical health, emotional functioning, and social functioning of the children were also significantly reduced to some extent. Fortunately, after anti-allergic treatment, the quality of life can be significantly improved. We are very impressed to find that not only the children, their parents also experience decreased quality of life in all domains in their daily life. Such impairment was again more severe in those with VKC, AKC than those with PAC and SAC. The reduction was most dominant in worry and daily activity of the parents. Their quality of life improved after treatment in the different subscales in the parents. Here shows the total quality of life scores were reduced in parents. The subscores of physical, emotional functioning, social functioning, cognitive functioning, communication, worry, daily activities, and family relationships were also lower in parents of AC compared with the control. A higher corneal fluorescein staining score was associated with decreased children's quality of life score and the decreased parents' quality of life score. Multiple consultation was associated with the parents' quality of life. In conclusion, AC is more than a conjunctivitis. It may also promote myopia and keratoconus progression. It is associated with conjunctival dysbiosis. It may change the tear film, and it may impair the quality of life in pediatric patients and their parents. Okay, thank you very much for your kind attention. If you have any questions, please feel free to contact with me by WeChat or email. Thank you.